everybody. My name is Peter Werwine. I'm Senior Editor at Managed Healthcare Executive, and I'm talking to you from Philadelphia today, where it's sweater weather. And I'm interviewing Amol Navathe, who's an assistant professor of health policy and medicine at Perelman School of Medicine at Penn. He's also commissioner of MedPAC, and famous in health policy circles as being a cost and claims data master and guru. And today we're specifically talking about a recent paper of his in the September issue of Health Affairs about special needs plans for people with end-stage renal disease, and very interesting. And I think the methods are challenging in this paper, comparing people in a special needs plan, Caremore specifically, to people being seen in regular Medicare fee-for-service. So that's a long-winded introduction, but thanks a lot for speaking with me today.
Sure, thanks for having me.
So let's just talk a little bit for people who aren't familiar about end-stage renal disease and Medicare. Somewhat strangely, if you're new to all this, people with end-stage renal disease, kidney failure, are, regardless of age, are covered by Medicare, right?
Yeah, that's absolutely right. So, back in 1965, when Lyndon Johnson signed the bill that established Medicare, and fun fact, Harry Truman was the first enrollee into Medicare, first beneficiary. So subsequent to that, and patients with end-stage renal disease were added as part of eligibility regardless of age. So you're absolutely right. So if you're 45 and have ESRD, then you are eligible for Medicare.
And I think that started in 1972 and was result of some rather famous testimony before some congressional committee. So they were sort of carved out. And although it's sort of an oxymoron to speak about Medicare for all for a specific group, this is a case where you're extending public payment to a particular group of people with a particular disease, regardless of age. So it's sort of an interesting area to look at in terms of a public payer, right?
Yeah, I think that's right. I mean, there is, I think, some specific rationale behind it, if you will, and you alluded to the testimony back in the 1970s. I think we think about it rationally. Even today, many patients with end-stage renal disease, it's almost synonymous with requiring or undergoing dialysis. And dialysis typically, at least the traditional dialysis that's most prevalent, called hemodialysis, requires patients to be dialyzed for basically 4 to 6 hours, usually 6 hours a day, for 3 days a week. And effectively renders them very difficult to employ. Therefore, they oftentimes end up, basically functionally disabled, and therefore financially more dependent, if you will, than other folks who have other conditions where they are not required to sit in a chair for 6 hours a day, 3 times a week. So I think that's part of the rationale there as well.
Yeah, it makes sense for to sort of socialize the cost of this care, given that they are probably have very difficult time participating in the workforce, and therefore employer-based insurance wouldn't be available to them even if they were working age.
Exactly.
But this study of yours is also about something that many people, even if you're in this field, are not all that familiar with, which is something called special needs plans. And I think they date from the early 2000s, 2003, correct? Something like that. And these are sort of Medicare Advantage-like plans. In other words, some sort of capitation for specific populations, correct?
Yeah,
As the name implies, special needs.
yes, no, but you're absolutely right. I mean, I think oftentimes we think of them as a subset or specialized set of Medicare Advantage plans. That's correct.
And so there are in fact special needs plans for people with end-stage renal disease.